Hello, I'm Prashant. I'm one of the radiologists at University of Iowa Hospitals and Clinics, and today I have an honor to talk to Dr. Brian Ghoshhajra, who is the Service Chief of Cardiovascular Imaging at Mass General Hospital in Boston, Massachusetts. Thank you for taking out the time to talk to us.
Thank you for inviting me. It's my honor.
Sure, thank you. I think a couple of things that I really am interested about how you do things. First of all, given that how well you have established your acute chest pain emergency room program, I wanted to know how do you think that your cardiac CT program has impacted management of patients coming in with acute chest pain?
So I think it's important to remember we set this up after much research, published research by many leaders in the field. So in a lot of ways, I'm not a chef, I'm just a cook. And I'm just following the recipe that's been iterated by those standing on the shoulders of those giants. That said, when we do a randomized controlled trial, it's a controlled setting. And so one of the things that we knew when we decided to roll this out for clinical care, it was important to have a task force that was multidisciplinary to set expectations. So we didn't know how things would work exactly to the minute detail when doing it outside of a trial. But we tried to follow those rules pretty carefully. That meant involving both the referring physicians, the recipients, the other parts of the imaging and cardiology and medicine departments and emergency medicine. That multidisciplinary task force was very helpful to catch them up on the literature that you and I read as part of our daily work. So that was telling, and one of the things that emerged from that was a desire to keep quality high. So they saw the great results that some of whom I work with and some at other hospitals around the world. So they thought we'd benefit most from maintaining those kind of standards. So we could educate on those standards. We also decided to create our own registry to ensure that we were meeting those standards. It's interesting when you run a trial, you have to do it during the hours that the recruitment's available. You don't get to say no in a clinical care, so there was a potential for very disparate responses. A patient that comes in at night might have to wait for a while till we're available. And we found that actually we had favorable results despite that. And also that because we had done some of the research trials, the results were actually better than some of the trials. No, that's partly because it's the same technologists, physicians interpreting and receiving, scanners get better, hospital processes are learned the hospital's kind of a living organism. So we were pleased, but we were very careful in rolling this out, and we still, for the most part, follow exactly the way that the trials were run.
Okay, that's great. But in your experience, what has been, let's say, for many other people who are trying to establish or make similar kind of a program, what would be at least two limitations you think in establishing this kind of a setup? Like, what are the roadblocks rather than limitations, what you would say?
So I think that the biggest roadblocks are going to be the organizational challenges. So it's really not that difficult to set up an ED program within an existing cardiac CT program. So it's sort of like if you want to make $1 million, start with $1 million. If you start with a successful outpatient elective program, you'll have worked out all the logistics of educating all the personnel along the imaging chain. And at least some of the physicians in your hospital will be used to receiving the reports, and hopefully they're good and accurate reports. You've got good cath correlations. You've got the technology established. So if you can start slow and start elective and then roll out your ED program, that can be very helpful. So it's in some ways, my task wasn't all that difficult. Engaging new providers, and I say providers, not just physicians, because you have all types of practitioners that might be involved in your coronary CTs and the ED, be they nurse practitioners or physician assistants, residents, fellows from the other specialties. So I think that's a vital thing, is to involve everybody and make sure that they are up to speed. And again, starting slowly. So we run 7 days a week now, but we started with 5 days a week.
And I also learned that during this FSCCT as well as before, there are many new things that you are bringing up. For example, scanning patients without heart rate, like without beta blocker, with end systolic scanning, and now this SCCT learning about nitro patch instead of giving sublingual tablets. How is that working out? I think these are the things that are partly the challenges in cardiac CT imaging, and how are these working out for you?
It's good. So when I came about a decade ago, I started my imaging fellowship, and I wrote I read actually a book by Atul Gawande. It was about being better and how to iterate and make your life as a physician. And one of the things that stuck with me was he said you don't need a grant to approach the world as a scientist. And so for me, it was counting something. And back then, as a fellow, it was radiation dose. So we were just becoming aware back in 2008 of the risks of radiation and the fact that we could dramatically reduce doses by making some simple changes. So the things that we did a big regression analysis over thousands of patients and found out what we knew all along, which is what the protection trial and others have shown us, that if you can stick with prospective triggering and lower your KV when possible, that's the biggest two drivers out of all the factors. So we kind of did the same thing with our protocols, and we've learned that with the right technology, and it's very scanner specific, and so we became experts in our own little domain of our scanners, which have evolved over time as well. We've learned we can compensate for arrhythmia and tachycardia in ways that don't require as much medication or even any heart rate control the way we did formerly. And we've published these results, so it's legitimate. I would also say we would never consider not doing all the medications. There's great guidelines from FSCCT. I think if you're starting out, you follow that recipe to the letter, and you start, and then you work on it, so you count things. So we've done that, and one of the best ideas that we had actually came from one of our technologists that said sometimes patients come from the wards and they have a nitroglycerin patch on, and why can't we do that? And I said, well, Fred, we can't do that because.
Actually, it's a great idea, and I don't know why we don't do that. No one's ever written about it, so why don't we
get an IRB and test it? So it started with counting something and just kind of iterating on daily process, and it turned into more original research. Well, these are just small things. These are technical acquisitions, but there's a rich life in that, and I think anything you do in life, you should try to do better and keep it interesting by approaching it as a scientist.
That's a great advice. I think going with the advice that you are giving, I just want to ask you, for people who are in training or as young physicians, looking up to you and other leaders in field of cardiac imaging, what would be, I would say, one or two advice that you would want to give and that you think are the most useful for them to grow in future?
I may be biased because I work in an academic center, but I'm certainly not I wouldn't consider myself a leader. I'm just a practitioner, but I think staying curious. I think what really, what crosses boundaries and breaks down walls is the scholarship. So this is a shared specialty, and whether you're a cardiologist or radiologist, I have internal medicine colleagues. We also collaborate and publish with our ED physicians, so emergency physicians are also very scholarly. And I think if you come to the table, in really any part of medicine, it doesn't matter whether you're on the tenure track at a big university or if you're in a small town, medicine is an academic field. And it's how many things have changed over the course of our, at least my short career, and sometimes you're thinking, does a 180 based on new data? And we should be prepared for that always. So I think if you bring scholarship to the table, and you're not across the table, but you're on a round table together, and you're working to do the best for the patient, you'll find it a rewarding career, and I think you really will find there's very little adversarial, and you're really on a team that's working towards a common goal.
That's a great advice, and I think for a lot of people like me to follow for future. Thanks a lot, Brian. Thank you for your time.
Thank you, Prashant.
Yeah, thanks.